Mhm. Okay. Okay, so hello everyone to this second meeting of our pathology resident-led live unknown slide sessions, or PRLUSS as I like to call it. This is, for those of you who don't know what this is an informal way for us residents to get together and look at some cases together, right? Share some knowledge. What I know, what you guys know, we share among ourselves and we learn from one another. I am still in training. I'm a PGY5 pathology resident in Germany. And yeah, so I don't have any pretension of being an expert. So the only thing that I'm trying to do is that I'm trying to encourage you guys to engage in pathology education as well, not just learn, not just be on the receiving end, but also try and share the knowledge that you've learned, because this is valuable. And future good teachers are made this way by practicing. It's like with exercise, it's like with everything else, you have to practice. If you don't, you're not gonna get there just by doing nothing, right? So this session's topic is on ovarian tumors, which is, I have to admit, a topic that I'm not very familiar with. So, but I've put together some info and some interesting cases. Most of them I've seen during my observership at the University of Alabama at Birmingham. So they're pretty interesting cases, rare cases. I hope you'll enjoy them. And I've put together some short info on these tumors so that you can have we can discuss it now and for later. Okay, let me see. So a few housekeeping items. We have some upcoming meetings. So Dr. Felipe Ruiz, or because we're very informal here, Felipe was very kind and wanted to, take the initiative to present himself, because as I said, this is an open thing. I'm not here hosting every session. This is not you watching me and listening to me talk about stuff. It's about us engaging. So he kindly wrote to me and asked me if he could present something on vulvar intraepithelial lesion. And I said, okay, fantastic. And I encourage every one of you to reach out and have the same initiative, because this is great. He's a PGY2 APCP resident at the University of Miami, Florida. And this will happen on another Saturday. The reason why we're doing this on a Saturday is that it accommodates the time zone differences. I know most of you are from the US, not all of you, but some at least. I think the majority is from the US. So I've listed here the times in Central Time zone. But if you think that Saturday is not working for you for any reason, or that the hour is not okay, we can adjust it. This is very informal, like I said. It's something that we do together, So on Saturday, June 22nd, we have Felipe presenting as going through the whole spectrum of vulvar intraepithelial lesions. Then on July 6th will be our next regular meeting. And according to the last poll that we did on which topic should we approach in our next session, pink renal tumors part 2 was at the top with the most votes, but we decided to, for variety's sake, to change it a bit and first do ovarian tumors today, and then maybe in a later session do the pink renal tumors, the second part. So according to that, to your wishes, to the Vox Populi, right? I'm going to do the second part of the pink renal tumors on July 6th. And another great initiative from a dear friend of mine and former co-resident, Aminia Cerbonoiu. She's a PGY5 resident at the Oncologic Institute of Bucharest, if you want me to translate it. She will be going with us through some breast pathology cases. The exact topic remains to be determined. We have some idea that it's going to be either fibroepithelial lesions or papillary lesions, whereby we kind of tend to favor the latter. So stay tuned. This will happen on July 20th. The hour is the same, 11 a.m. Central Time. So without further ado, let's start with cases number 1 and 2. I lumped it together. Actually, I wanted to present another case here, a separate case, but I didn't have the time to put all of the info together. So you'll excuse me if I'm going to keep that for a later session or maybe for a tutorial on Twitter. Okay, so ovarian tumor, right? Macroscopically, grossly, it's a cystic tumor. It has a lot of sebaceous material in it and a lot of hair fragments. So it kind of already says a lot about what this tumor is. And under the microscope, we see different areas. This tumor is like a histology atlas. And my explanations are going to be a bit more basic than maybe you would expect for a regular webinar, which this isn't, as I said. That's because we also have a lot of pathology aspirants among us. So I wanted to keep it like at a level of understanding that we can all relate to. So we see different areas. It's like a histology atlas. We see areas where we have squamous epithelium, mature squamous epithelium, keratinizing, a lot of keratin debris that corresponds to that material that I said we could see in the cis lumen of these tumors. We also have sebaceous glands in this field. Other areas show smooth muscle bundles admixed in the stroma. We have intestinal type glands, beautiful intestinal type glands, like in the atlas, right, with absorptive enterocytes that have pink cytoplasm with no mucin in it, and then scattered cells that have this goblet cells, right, that have this engorged cytoplasm with mucin and look like a goblet. Exactly. Now, other areas. Other areas show this sort of granular tissue, small cells with very scant cytoplasm, high NC ratio, but the nuclear bland and they're overall. Then we have these bigger cells, plumper, eosinophilic, that kind of look like pear-shaped. And another aspect to the left of the screen that is very paucicellular and very fibrillar, right? So we kind of get the sense of what this is, seeing all of these different mature tissues in one tumor. So this is, I'm gonna tell it right away because this is not what I'm trying to show you in this particular case. This is a mature cystic teratoma. And what I'm trying to show here is that mature cystic teratomas they have mature tissue, right? Different types of somatic tissue, but they can also show the thing is that when we think about mature and immature teratoma, we think about immature neuroectodermal elements. And sometimes, especially junior trainees, get confused when they see mature nervous tissue and think that just because it's in that category of neural things, that this represents immature elements in a teratoma and jump right into calling it immature. But this is not it. Mature cystic teratomas, yes, they can have endodermal derived things like the intestinal epithelium that I've shown. They can have squamous epithelium, ectodermal. They can have smooth muscle and adipose tissue from the mesoderm, but from the ectoderm, they can also have brain tissue. And this is actually cerebellum. This is cerebellar tissue with Purkinje cells, the plumper pear-shaped cells that you see in the middle of the screen. So this is still mature. We're not in the realm of immaturity. Another area showing exactly the same thing with mature nervous tissue that does not qualify as immature neuroectodermal elements in ovarian teratomas. Another thing that ovarian teratomas can do in terms of imitating central nervous system structures is they can have these papillary structures lined by these cells with, they kind of look hobnailed with eosinophilic cytoplasm. They're cuboidal to short columnar, bland round nuclei, monomorphic. These are structures of a choroid plexus-like structures, if you will. So the ovary just decides to make a brain of its own, right? One thing to mention here, just as a side note, is that maybe you've heard of the NMDA receptor-associated encephalitis that is sometimes associated with ovarian teratomas. There is also a book, I think it's called Brain on Fire, about a girl, a woman, young woman that went through the whole torture of experiencing that sort of encephalitis. It manifests with psychotic episodes, and it's a very dramatic clinical picture. Patients are sometimes misdiagnosed with schizophrenia before they get imaging studies, and the clinicians discover this ovarian mass, and it subsides after after the ovarian teratoma is being removed. So it's clearly related to that. What you can see under the microscope in NMDA-associated encephalitis is in the teratoma, you're going to see mature nervous tissue, but it's not going to be, as in this example that we had, it's not going to be just sitting there unbothered by anything. It's going to be surrounded by lymphoid aggregates, and especially by lymph follicles with germinal centers. So the lymphatic system, the immune system, reacts to that mature nervous tissue. And because this nervous tissue is developing in an area in the ovary where it is not protected from the immune system through that blood-brain barrier, the immune system is going to recognize it as foreign, and it's going to build autoantibodies, which are in turn going to affect the nervous system, right? Okay, that was just a side note. What I wanted to show you in this case, I tend to talk a lot, so stop me if I do a lot of parentheses and I derail too much from the main scope of the talk. But what I wanted to show you here is this area. This was one area in that teratoma, in the same teratoma, which showed this sort of it was like a nodular appearance, was a nodule in the wall of the cyst that was grossly seen as a yellowish nodule, solid area in that cyst wall, in that otherwise thin cyst wall. And it showed these nests and trabeculae scattered throughout this prominent fibromatous stroma. You may notice to the lower right edge of the photo that you see some cystically dilated structures with pink amorphous material inside them that kind of imitates thyroid follicles. But this would be to expect, right, in an ovarian mature cystic teratoma, right? Because thyroid tissue can be seen there. Going to showing a bit of that's exactly what I wanted to show, is the ovarian stroma, normal ovarian stroma that we have, and then this nodule that sits inside of the cyst wall, composed of fibromatous stroma with these scattered nests of variable sizes and prominent blood vessels. Again, the same picture showing the same arrangement of cells. And if we were to go to a bit of a higher power, we see these nests are very monotonous. They're variably sized, but the cells themselves are very monotonous. They have round nuclei, and the quality of the picture is admittedly not that good, but if it were to be, you would see a salt and pepper-like chromatin. Okay, sorry. Yeah, so showing you some immunohistochemical stains, synaptophysin and chromogranin A were diffusely positive in these tumor cells, and the Ki67 was low. It was like less than 2%, 1%, I don't know exactly. So to summarize the staining profile of the tumor, now my question for you would be, because we like to keep this interactive, right? What do you think this could be inside a mature cystic teratoma? What am I doing? Yes, paraganglioma. A good differential, a very good differential. But this is not it. Paragangliomas would be, let's say, this tumor is GATA3 negative. Other thoughts? No? Well, this is an ovarian carcinoid arising in a mature cystic teratoma. It's something that happens. Ovarian carcinoids can happen in mature cystic teratomas. It's kind of a common association. And what I want to show you now is that regarding neuroendocrine neoplasms in the GYN tract, right? They are rare, as you might expect. There's been a shift from the last edition, the fourth edition, the 2014 edition of the WHO to the 2020, the fifth edition, in terms of nomenclature and in terms of categorizing neuroendocrine neoplasms in the GYN tract. Formerly, for every single location, we used to have a separate subchapter of neuroendocrine neoplasms occurring in that location. Now, there's been a tendency to harmonize terminology for neuroendocrine neoplasms in all organ systems. So in the new WHO, there's a dedicated chapter of neuroendocrine neoplasia in the whole GYN tract, with the exception of the ovary, and you're going to see why that is. So just like a quick summary of neuroendocrine neoplasms, everywhere not in the GYN tract, but specifically in the GYN tract, we have neuroendocrine tumors, which are well and moderate, which can be well and moderately differentiated. They're epithelial tumors with neuroendocrine differentiation on H&E, meaning they have that nested or trabecular or epithelial, in a sense, growth pattern, and they have those monomorphic round nuclei with that finely speckled chromatin, what we call salt and pepper chromatin. And they also show positivity for neuroendocrine markers, which may be variable, but at least one neuroendocrine marker should be positive from the first generation markers, which are synaptophysine, chromogranin, CD56, whereby CD56 is positive in many tumors, but well, that's not a topic of our discussion. And this from the second generation markers, INSM1, which is rarely used for this diagnosis anyway. In the GYN tract, as opposed to the GI, where you might think we use the Ki-67 to, of course, together with the morphology, to grade these tumors into G1, G2, and G3, well differentiated, moderately and poorly. In the GYN tract, there is no recommendation on reporting and using Ki-67 yet for grading. So grading is based on morphology alone. It's based on nuclear atypia, mitotic rate, and necrosis, with G1 nets having low-grade cytology, rare mitoses, and no necrosis, and G2 nets having sort of mild nuclear pleomorphism, whereby under pleomorphism, we understand variation in size and shape of the nuclei. 5 to 10 mitoses per 2 square millimeters, and they may or may not have necrosis. One thing to remember is that there are no poorly differentiated G3 nets in the female genital tract. This is in contrast to the GI, which is like a standard thing that we think about when we think about neuroendocrine neoplasms. On the other hand, we have neuroendocrine carcinoma, and we have two distinct types that we categorized mostly based on cytology, which are small cell neuroendocrine carcinoma and large cell neuroendocrine carcinoma. Small cell neuroendocrine carcinoma, when we think about the typical morphology, we think of a sheath-like growth of small atypical cells with that high NC ratio, which results in, because the cells have less cytoplasm, don't have enough cytoplasm, the nuclei tend to push one another. And they make room for one another, which is something that we call nuclear molding, that the one nucleus pushes into the other, and the other one kind of makes room for it, kind of gets indented. And this is something that happens because they don't have that much cytoplasm to keep the cell nuclei apart, right? The finely stippled salt and pepper chromatin persists in these tumors, and there are no prominent nucleoli. And of course, we like to see neuroendocrine differentiation in terms of immunohistochemistry using the markers that we've mentioned. Large cell neuroendocrine carcinoma, on the other hand, shows usually in terms of architecture, more trabecular or insular growth. It has larger pleomorphic cells with larger amounts of cytoplasm. There's no nuclear molding because now there's enough cytoplasm for the nuclei to kind of respect themselves, to be one another, not touch one another. Usually we see prominent nucleoli, and of course we again expect to see neuroendocrine differentiation, especially in large cell neuroendocrine carcinoma. We expect to see neuroendocrine differentiation for a definitive diagnosis. Of course, we can see mixed tumors, small cell and large cell. But just one thing to remember from this whole thing is that NETs and NECs, neuroendocrine tumors and neuroendocrine carcinomas, are different entities. They're not on the same spectrum. You don't go from a G1 NET to a G2, G3, and then you go to a neuroendocrine carcinoma. It's not like that. They're different clinical, pathologically, and molecularly. Just one thing to remember. Now, neuroendocrine neoplasms in the GYN tract, overall rare occurrences, except in the ovary. In the ovary, we mostly see neuroendocrine tumors, and they're usually associated with mature teratoma. That's why I wanted to show you this case. They can rarely be associated with yolk sac tumors, Brenner tumors, but usually with teratomas. And in the rest of the GYN tract, the vagina, the cervix, and the endometrium, we mostly see neuroendocrine carcinomas and almost never NETs. And it's important to think about these subtleties in terms of incidence of different tumors when assessing, when being faced with such a rare occurrence in the GYN tract, right? When it comes to neuroendocrine carcinomas in other locations, not in the ovary, common things are common, right? So first, be sure to rule out things that are commonly seen in those organs, such as a poorly differentiated squamous cell carcinoma in the cervix, right? Which may imitate, it's one of the main differentials when you're talking about neuroendocrine carcinoma everywhere. In the endometrium, think about dedifferentiated or undifferentiated carcinoma. And the thing is, some authors believe that because neuroendocrine carcinomas, pure neuroendocrine carcinomas, are so rare in the endometrium, most cases might actually represent undifferentiated or dedifferentiated endometrial carcinoma with a slightly more pronounced expression of neuroendocrine markers, because undiff and d-diff carcinomas, endometrial carcinomas, may express neuroendocrine markers. But there's an arbitrary threshold of 10% that we set, saying that they should show less than 10% expression of neuroendocrine markers in order to be able to diagnose them as such. Of course, along with other distinctive features. But some believe that they may express what do you do when we have, how do you assess this 10%? What if you have 15%, right? So that's the main point to remember from this. Okay, moving on. Ovarian NETs, ovarian carcinoids. Why are they listed separate? That's because there's a higher incidence. There's a higher incidence of NETs in the ovary compared to the overall incidence of neuroendocrine neoplasms in the GYN tract. And they have strikingly better prognosis than other neuroendocrine neoplasms of the GYN tract. They are of teratomatous origin. It's not a somatic type tumor. And it's actually what it represents is a well-differentiated neuroendocrine tumor of the ovary, resembling those of the GI tract. And it originates, why do we say they're teratomatous? In the sense that they originate from neuroendocrine cells of intestinal epithelium of mature teratoma. Why are they still called carcinoids, you might ask? Because in many organ systems, we tend to, in the GI as well, we tend to go away from this term of carcinoid. The palm path people are a bit reticent, they're still at carcinoids. But in most other organs, when it comes to neuroendocrine neoplasia, we kind of move from carcinoid to calling them well-differentiated neuroendocrine tumors. Well, I don't know for the lung people, but in the GYN tract, we have pretty clear reason why we like to keep it at carcinoid. That's because we're trying to, the term tries to reflect the excellent prognosis that these tumors have, and that there is no clinical relevance for grading. Because if you were to say well-differentiated neuroendocrine tumor, G1, you usually have to use that adjunct of G1. So this has no clinical relevance. They're essentially almost always have an excellent prognosis, and they're cured with complete excision. Even in their coding, in the ICD coding, they get a 1. They get /1, again to reflect that their excellent prognosis and the fact that adjuvant therapy is generally not necessary. Morphologically, we have different patterns. We have the insular carcinoid, we have the trabecular carcinoid, we have the stromal carcinoid. The insular one is the most frequent. 50% of ovarian carcinoids look like that. As the name implies, they're made of solid nests and some acinar tubular structures, which are usually seen at the periphery of these solid nests. The nuclei, again, monomorphic, round oval, salt and pepper chromatin. Sometimes they have basally located red-brown cytoplasmic granules, and morphologically they resemble mid-gut nets from the small intestine and appendix, for example. Trabecular carcinoids are rare. As the name implies, they're made of trabeculae cords and the parallel and anastomosing ribbons of cells. I'm going to show you a pic in a bit. The nuclei look the same, but morphologically, because of that growth pattern, they resemble fore and hindgut nets from the stomach and rectum, respectively. Stromal carcinoids are the second most common type of carcinoids. And what it is, it's like you have an insular or trabecular carcinoid, more frequently trabecular, that is either intimately admixed or separate, but it's juxtaposed to thyroid follicles. Because we know the idea of stroma ovari when we have it's a teratoma, right? That it's composed predominantly of mature thyroid tissue. And when you have admixed carcinoid with that, like I said, either you have the carcinoid components, it's intimately admixed with the thyroid stroma component, or it is just juxtaposed. We're talking about the stromal carcinoid. Of course, you may see mixed patterns of all of these, right? Insular, trabecular, and the same tumor. This is a typical example of a insular carcinoid where you see those solid nests that are punctuated by microacinar structures, especially at the periphery of the solid nests. On the left-hand side of the screen, you see an insular carcinoid that has the acinar structures. You can have, of course, you can have nests, but you can also with those acinar structures, but you can also have the tubular structures on their own. And then the trabecular carcinoid, which has beautiful these branching and anastomosing trabeculae, essentially. Stromal carcinoid, on the right-hand side of the screen, the lower left picture shows you juxtaposed carcinoid, lower left, and then the stromal, the stroma component, the thyroid component on the upper right part. Another pattern that is very uncommon and very bad in terms of this is the only pattern that has a worse prognosis compared to the others, and this is the mucinous or goblet cell carcinoid. This is graded in terms of well differentiated when you have well-formed glands with goblet cells and mucin pools, and atypical mucinous carcinoid when they tend to fuse the glands and form solid or cribriform structures. And then the poorly differentiated mucinous carcinoid is when you have solid growth, or you have signet ring cells, we have prominent atypia, high mitotic activity, and mucin loss. And this is the only one that has a poor prognosis, like I said, compared to the other morphological subtypes. We're not going to spend too much time on the IHC. Neuroendocrine marker expression is variable. Almost always at least one is going to be there. They're almost always CDX2 positive. They're typically CK7 positive and CK20 negative. And in mucinous carcinoid, on the other hand, you're going to have CK7 positive and CK20 positive as well. In the stromal carcinoid, the stromal ovarian component is going to be positive for the thyroid markers, TTF1, PAX-A, thyroglobulin, whereas the carcinoid component is going to show neuroendocrine marker expression. So you're going to see that sort of two immunohistochemical phenotypes in the same tumor. And the Ki67 is always low in primary ovarian tumors. One thing to remember that I want to point out is that, of course, there are differentials, right? And for the first thing that you have to think about when you see a neuroendocrine tumor, a well-differentiated neuroendocrine tumor in the ovary, is they're still rare, although they're more common than other neuroendocrine neoplasms in the GYN tract. They're still rare overall. So thinking about a metastatic net from the GI tract is the first thing that should come to mind. And the thing is that neither morphology nor immunohistochemistry alone are helpful in that sense, because they're both going to be positive for neuroendocrine markers. They're both going to be positive for CDX2. They're both going to be CK7, CK20, 7 positive, 20 negative. So that's not going to help you in that sense. This is on the right-hand side. I've listed some features that are helpful in this distinction, and this is a table that I've adapted from one of Dr. McCluggage's excellent talk on neuroendocrine neoplasms in the GYN tract. And one of the features that helps you is the presence of a teratoma. You don't see association with a teratoma unless you have a pre-existing ovarian teratoma and there is a well-differentiated GI net that is metastasizing to that ovary involved by teratoma. But this sort of occurrence is even rarer than having a primary ovarian carcinoid in a mature cystic teratoma. Of course, if you have the laterality, if you have bilateral involvement of the ovaries, that's mostly indicative of a metastatic WD net. If you have surface involvement of the ovary, if you have lymphovascular space invasion, how did the tumor get there, for the lymph vessels? So again, these are, or if you have extra-ovarian involvement, another thing, because primary carcinoids of the ovary, good prognosis. There are some very rare metastatic cases, but exceptionally rare. So if you see extra-ovarian involvement, maybe asking your clinicians to look and exclude a metastatic tumor from another site, especially the GI tract, it's essentially a must. You always have to include this in your report or communicate this to your clinician. And another thing regarding differential diagnosis, apart from metastatic nets from the GI, for example, are somatic type malignancies that occur in the ovarian teratomas. For example, papillary thyroid carcinomas. 1 second, Joshua. So papillary thyroid carcinomas, if you look at this very beautiful example that I've collected from Twitter, you can see they can be very, very similar in their growth pattern, especially when you have PTCs that grow in this follicular or solid pattern with this solid pattern of nodules of cells. Especially in those tumors, you're going to see a morphological overlap. So pay attention, one, at nuclear morphology, the PTC nuclei, right? Orphan, Annie, grooves, irregularity, overlapping, nuclear pseudo-inclusions, right? And versus the salt and pepper-like chromatin of the nets. And of course, immunohistochemistry is going to help because PTCs are not going to stain like WD nets, like ovarian carcinoids in this sense. Okay. What was the question?
Oh, just for the previous slide. Sorry, I just want to clarify this differential.
This.
No, the very last slide you were just talking. Oh yeah, sorry, that's a different question.
Yes.
This slide, this differential is just for anything neuroendocrine appearing in the gynae tract, like kind of broadly speaking.
Well, you can, but I cannot think essentially you mean the differential net carcinoid in this sense versus PTC? Or
Yeah, I
Or with
guess
the
like
with the metastases? What are you
um
referring to?
yeah, I'm referring to the box in the top left.
Oh,
Um yeah, like
this is the differential. This is the differential for the ovarian carcinoid, especially.
okay, got it. Thank you.
Yeah, because
Yeah,
in most other, I mean, I'm not aware, but in most other organs of the GYN tract, like I said, you usually have neuroendocrine carcinomas, not neuroendocrine tumors. Having a
right.
net in the vagina, in the endometrium, for example, if you have it, I don't know, send me a pic. I want to see it. It's
Okay.
would be
Yeah.
great, but usually you don't get that. You get neuroendocrine carcinoma, so the differential is going to be based on the location. For the cervix, like I said, you're going to think of a poorly differentiated squame. For endometrium, you're going to think of D-diff, undiff carcinoma. So that's going to be the differential. But for the ovary, where you mostly get nets, you're going to have to think of nets coming from somewhere else, and usually they come from the GI tract. And
Okay.
yeah,
Thank you.
no worries. Okay, moving on. Regarding KI, I told you that Ki67 doesn't play a role in grading neuroendocrine tumors in the GYN tract, but it does seem to help, according to this very, very good article. I find it's makes a good point in the differential between primary ovarian nets and the metastasis from the GI tract, let's say. Because this article shows that the KI is increased in metastatic tumors as opposed to primary WD nets of the ovary, which we call carcinoids, which have a low or a lower Ki67. And also, it seems to have prognostic significance in the setting of primary carcinoids, because some primary carcinoids can have a higher Ki67, even if they're primaries, right? So these carcinoids tend to behave worse than those that have a low Ki, as in the case that I've shown. Last thing about ovarian carcinoids, um, like I said, just things to remember. They have an excellent prognosis, but there is one caveat. 1/3 of patients, especially the ones that have uh, insular carcinoid, can have cardiac involvement, can develop carcinoid syndrome with cardiac involvement, and especially cardiac involvement is the one that is conferring the higher risk of mortality in these patients who develop carcinoid syndrome. So there are some histologic features, like I said, the insular growth pattern, a size of more than 7 centimeters, which can predict the risk of developing carcinoid syndrome in these patients. So maybe including the growth pattern in your report and suggesting to the clinician that this is a possible occurrence and that they should follow up the patient, although they're essentially cured in terms of tumoral manifestations, recurrences, metastases with complete excision, that does not exclude the fact that they can develop carcinoid syndrome and they can develop heart failure subsequently. So they should be followed and monitored cardiologically. And the other thing, like I said, rare cases of extraovarian spread, frequently involving either the lymph nodes or the liver, have been reported. So it's not a completely, it's considered of low malignant potential. That's why it gets /1 in the ICD coding. So although that's the thing to remember, although prognosis is generally excellent, remember possibility of carcinoid syndrome with high mortality if it affects the heart, and rare occurrences of extraovarian spread, which are possible. Case 3, are you ready? Right. I'm wondering, wait a second. Uh, do you guys know how to, wait a second. No, sharing this. Okay, never mind. So this is a tumor, ovarian tumor. Grossly, it was mostly solid, especially at the periphery of the tumor, with central areas of edema and cystic change. At scanning magnification, what we see are at scanning magnification, actually what we can see is an alternation of cellular areas, especially towards the surface of the ovary, and more hypocellular areas that seem to be loosely collagenous to edematous. And another thing that we can notice is a prominent vascular pattern with some ectatic and sometimes branching blood vessels. Going a bit to a higher power, we see that there's a sort of pseudolobular pattern that we've already picked up on at scanning magnification. Now going to higher power, we see the cellular lobules, and then in between the stroma, loose, collagenous, edematous, and these thin-walled, dilated, and sometimes branching blood vessels, which we like to call staghorn-like blood vessels, right? Another area showing the sclerosing stroma in between these pseudolobules, because they're not really well-formed discrete tumor lobules, but they're actually just pockets of hypercellularity within this fibroedematous stroma. And again, the dilated, thin-walled and branching staghorn-like blood vessels. A close-up on the hypercellular areas shows us, I think we can also tell from this power there is an admixture of spindle and epithelioid cells. But if we were to go again, another area where I'm trying to show this prominent staghorn-like vasculature, that kind of rings a bell. You know, classically we talk about staghorn-like vessels when we are talking about a solitary fibrous tumor. I'm gonna tell you this is not a solitary fibrous tumor, although they can occur in the ovary, and this is one of the main differential diagnoses. But just wanted to point out that staghorn-like vessels are not specific or pathognomonic for solitary fibrous tumor. That can also occur in other tumors. Okay, let's look at the cells. Focus a bit on those pockets of hypercellularity. So we have this admixture of two cell populations. We have these plumper epithelioid cells with pale eosinophilic cytoplasm and pretty monomorphic brown ovoid nuclei. And then in between, we have these spindled cells with a bit of eosinophilic cytoplasm, bland nuclei. And the cells seem to be admixed in a sort of jumbled pattern. It doesn't seem to be a pattern of any one of these cell populations. Admittedly, the epithelioid cells are sometimes seen singly or in small clusters or hordes, but and the spindle cells, they kind of form small, short fascicles, but overall there's this impression of like taking two cell populations and putting them together. Another area where we have a bit of more roughly equal proportions of the two cell types. We see the spindled cells, bland spindled nuclei, eosinophilic cytoplasm, and then the rounded epithelioid cells with somewhat clear vacuolized pale eosinophilic cytoplasm and the round nuclei. Another area that shows a bit more sclerosis inside these cellular pseudolobules, with the epithelioid cells predominating in this field. So we see that we can have varying proportions of the two cell types. And focusing on the cytology, on the nuclear morphology, we see the nuclei of the epithelioid cells are commonly vesicular, have vesicular chromatin, and have prominent nucleoli. they're pretty bland. There's no significant cytological atypia. There are no mitoses. The staining profile of this tumor, if it helps. So in the round cell component, in the epithelioid cell component, we have positivity for sex cord markers, such as calretinin and inhibin. We have positivity for melon A, because we see that these cells, they're kind of mildly luteinized with that vacuolated pale eosinophilic cytoplasm. Whereas in the spindle component, we have positivity for SMA, CD10, W21, whereby CD10 and W21 kind of go together in this group of sex cord markers. Like I said, STAT6 negative, so this is not an SFT in this case, and cytokeratin, broad spectrum cytokeratins were negative as well. Now, opinions on this very, very rare tumor, actually.
I briefly thought, could this be a clear cell? But I don't think that anymore. This kind of reflects something sex cord-stromal.
Yes, it does. Very well. Although clear cell, which would be from the epithelial surface epithelial category of ovarian tumors, may enter the differential, as it can also show prominent sclerosis in parts and the clear cytoplasm, but this is not it. That's a very good differential, luteinized tecoma. Tecoma is way more frequent than this is. It's in the differential. We don't use the term luteinized tecoma anymore unless we are talking about that entity called luteinized tecoma with associated sclerosing peritonitis. But tecomas in general are a differential diagnosis of this, and we're going to get to that in a bit, but this is not a tecoma. Other considerations.
Consider fibrothecoma.
Fibrotecoma is a term that some authors don't agree with or don't endorse, in the sense that there's a lot of overlap between fibromas and tecomas in a sense. But tumors are in a sense that in fibromas, you can have areas of luteinized cells or areas that kind of look like tecomas. And in tecomas, you can have fibromatous spindled areas. But depending on the predominant morphology, you should be able to categorize them either as a fibroma or a tecoma. At least that's what some experts in the field recommend to do. But this is not a fibroma, this is not a tecoma, so it is not a fibrotecoma. Another idea. Let's reiterate the morphology. Alternation, pseudolobular appearance. There's a pseudolobular appearance at low power, right? There's this, look, pseudolobular appearance. Pockets of hypercellularity that don't necessarily constitute well-defined lobules, just areas of cellular accentuation, alternating with more edematous, fibrous, or sclerotic areas, right? The Staghorn-like vessels, and the two-cell population, that mixture of epithelioid, mildly luteinized cells, and spindle cells in a jumbled pattern. Put it in Google. You're gonna find. It's gonna give you the answer.
Yeah, I cheated and looked it up, but
What is it? Say it.
So I can say it.
Yes.
Okay, yeah. So the staghorn vessels, especially, and the pseudolobular architecture is a sclerosing stromal tumor.
Yay! This is a sclerosing stromal tumor. Yes. Good job. Although you cheated, but it's good.
I cheated. Not a good job.
Yeah. So this is a sclerosing stromal tumor, right? And what I wanted to show you, but okay, so sclerosing stromal tumors, before this article came to light, which is from 1973, Ovarian stromal tumors, the discussion regarding ovarian stromal tumors mainly revolved around the differential diagnosis between fibroma and tecoma, and which is seldomly relevant clinically, to be honest. But after 1973, when this tumor was first described, there's been an increasing interest in ovarian stromal tumors, and more, many more other tumor categories have been introduced since then, like the microcystic stromal tumor and so on. So sclerosing stromal tumor entered the game, and I really encourage you to read this article, although it's pretty old, but the morphologic description is great. And these morphologic features have been validated in recent studies. So it's a good article for a historical perspective, and to read about the morphology of these tumors, it's great. So I definitely recommend it. Now, sclerosing stromal tumors are rare. They represent less than 1% of all sex cord-stromal tumors. They tend to occur in younger patients. The peak incidence is between the second and third decades. And this is important because in comparison to its main differential diagnosis, which is fibroma and tecoma, fibromas and tecomas tend to occur in peri or postmenopausal patients more than in young patients, and as opposed to SSTs. So knowing the age of the patient is, like in most instances, very useful. They can occur in pregnancy. 14% of cases in one large cohort study occurred in pregnancy, and they tend to have a special morphology in pregnancy as well. The epithelioid cells, instead of being just mildly luteinized with that clear, actually vacuolated pale eosinophilic cytoplasm, they become strongly luteinized, and they may predominate over the spindled cells. So it's important to be aware of this variant morphology correlated with with pregnancy in this case. Clinically, they present with the patients are either asymptomatic and they're discovered incidentally on imaging done for other reasons, or they may present with abnormal uterine bleeding or abdominal pain. They usually show estrogenic manifestations, but less commonly than fibromas and tecomas. We're going to get to the differential soon. I'm going to show you a table where I put all of this info for you for further reference. Estrogenic manifestations in girls, it's going to lead to precocious puberty. In somewhat older women, it can even lead to endometrial hyperplasia and endometrioid carcinoma, right? On the whole spectrum of disordered proliferative endometrium to hyperplasia, atypia, and carcinoma. They may be associated rarely, very rare, with ascites or pleural effusion, which is the latter is incorporated in the so-called Meigs syndrome, where the pleural effusion resolves after excision of the ovarian tumor. And then very rarely they can be associated with Gorlin syndrome. This is more commonly seen with fibromas. Fibromas are more commonly seen in Gorlin syndrome. Actually, I think 35% of patients with Gorlin syndrome can have usually bilateral fibromas, very calcified fibromas. But rarely SSTs can be seen in this syndrome as well. So the hormonal manifestations, like I said, are rarer than in fibromas and tecomas, usually as estrogenic. And the prognosis is excellent. It's benign. There are no reported recurrences with complete excision. Okay. So I've listed here an article, again, just as a reference for you guys. And the gross images that I've shown here are from this article. It's a very good article. I encourage you to read it. Even gross day, you can kind of tell in most instances, not in every situation, but you can kind of, say whether this goes more towards a sclerosing stromal tumor, fibroma, or tecoma. SSTs tend to have this variegated cut surface, where they have solid areas, especially at the periphery, as seen in this picture, where you kind of see like yellow nodules at the periphery that are coalescing, like in the rim of the yellow rim of the tumor, with usually central areas of edema, sometimes prominent cystic change. Whereas fibromas, they're usually solid, completely solid, and they have a homogeneously white cut surface. Tecomas, also predominantly solid, also homogeneous cut surface, but mostly yellow. So you can kind of tell from grossing, and that's always satisfying when even from the gross morphology, you can kind of tell in what direction you're going with your diagnosis. Right. So sclerosing stromal tumor, regarding microscopy, there's one thing that I want you to remember, which is, okay, stromal sclerosis is a defining feature. It's in the name. But there are also other, additional essential features, or features that you might want to see in order to reach the diagnosis. And there are three main things apart from stromal sclerosis: the pseudolobular pattern, that alternation of hypo and hypercellular areas; the admixture of two cell types, the lutein, the so-called lutein cells, because they're mildly luteinized, which are epithelioid. They have pale eosinophilic vacuolated cytoplasm, brown vesicular nuclei with nucleoli, and the fibroblastic type, or spindle cells. All of this in a jumble pattern, no specific pattern. And the third feature is having prominent stack horn-like vessels, which we define as thin-walled, dilated, and sometimes branching vessels. Regarding the stromal sclerosis, it's a bit different depending on the area you're looking at, or the stroma itself. In the nodules, in the cellular pseudolobules, you're gonna almost always see fibrotic stroma, as we've seen in the picture. In areas in the hypocellular areas, you can see usually 95% of tumors will show this mostly loose collagenous, not that sclerosing as the name implies. It's usually more loose collagenous, even edematous stroma. But sometimes you may see prominent hyalization and keloidal type collagen, more in keeping with the name. But it can also see myxoid changes in sclerosing stromal tumor. And there are some authors that believe sclerosing stromal tumors with myxoid change lie on the same nosologic spectrum with ovarian myxomas. And some people really do believe they are the same entity, just at different ends of the spectrum. Some other authorities in the field disagree with that and say, okay, ovarian fibromas, ovarian myxomas, when taken for their typical appearance, are usually they look different. They have they're hypocellular with stellate cells with these branching cytoplasmic processes. The vascularity is not that prominent. Usually have delicate vessels. So there's an entire discussion on this. The differential includes lots of other sex cord-stromal tumors and even metastases to the ovary, such as the Krukenberg tumor, right? Because some of these epithelioid cells can, with their cleared out cytoplasm, they can mimic signet ring-like cells. But mostly we're going to talk about fibroma and tecoma because these are the most common, Right. So I put here a table for you guys with differential features, overlapping and distinctive features between SST, fibroma, and tecoma. So main things to remember is that fibromas and tecomas usually occur around 50 years in patients that are around 50 years of age, as opposed to SSTs. The median age for SST is 26 or 30, something like that. Most patients are under 30 years of age. And for example, for fibroma, while you may see stromal edema and cystic change, grossly, we said that most fibromas, typical fibromas, will have usually a solid, homogeneous white cut surface. Microscopically, fibromas can show sclerosis and usually do show sclerosis, but it's usually in the form of hyaline plaques, or the tumor is completely sclerotic and hypocellular. And you don't see that pseudolobulation with those hypercellular and hypocellular areas. You can have Staghorn vessels in a fibroma, and this is an important overlapping feature. And regarding the cellular component, you can have minor component of luteinized cells in fibromas, which does not preclude the diagnosis of fibroma when it's just a minor component of them. But you won't have that consistent jumble admixture of luteinized and spindled cells. For trichomas, on the other hand, again, the age, again, the fact that more microscopically, they can show stromal edema and cystic change. All of these three tumors can, but typically they'll be solid and homogeneously yellow on cut surface. And microscopically, while you can have sclerosis in trichoma, you can have fibrous bands that are separating the cells into a pseudo-lobular appearance. Usually in trichomas, the cells grow in a sheet-like fashion. But if you imagine having cellular septa, broad cellular septa, going through these sheet-like arrangements of cells, you're going to get pockets of hypercellularity and alternating with areas that are more sclerotic and hypocellular, and this is going to imitate that pseudolobulation seen in SST. So, but this is something that happens rarely in trichomas. Usually you're going to see hyaline plaques. Staghorn vessels may occur in trichoma, and trichomas, like fibromas, that can have minor components of luteinized cells, trichomas can have a minor component of spindle cells, fibromatous cells. But again, you won't see this consistent jumbled admixture of lutein and spindle cells. In trichomas, typically you'll have cells with ovoid, round nuclei, and this pale gray cytoplasm that have indistinct cell borders and grow in a so-called syncytial pattern. And if everything else fails, there's been a reported recurrent and arguably pathognomonic fusion seen in sclerosing stromal tumor, which is FLH2 Gli2 fusion. So if anything else fails, you can rely on molecular pathology to solve the issue. One last thing about SSCs, it's regarding mitotic activity. It's usually less than one mitotic figure per 10 high power field. But there have been reports of cases, and there is this one article by Goebel and colleagues who reported 6 cases of SST with up to 12 mitoses per 10 higher power fields. And in their cohort, they had one patient who showed a recurrence after 1 year after complete excision of the ovary with no adhesions. So as to show that there wasn't the possibility of a residual tumor was excluded. The authors of this study proposed the term mitotically active sclerosing stromal tumor as a correlation, as a parallel with the mitotically active cellular fibroma. Now, other authors have shown that these tumors with a higher mitotic weight tend to be slightly larger, and they may have ischemic type necrosis, but other authorities in the field disagree or don't necessarily endorse the term mitotically active sclerosing stromal tumor because it doesn't seem to have any clinical relevance apart from that case that recurred. It usually doesn't have any significance in terms of higher risk of recurrence or whatever. Case 4. You ready? Wait a second. I wanted to, sorry. Where were you? Case 4. Ew, sorry. Yes, this. Sorry, I'm just trying to do this and see if it yeah, didn't work. I'm sorry. Let's go back. Okay, so this next case is for us to what I want to illustrate with it is a thing that has been only recently extensively studied in the literature, and that is the occurrence of sclerosis in other sex cord-stromal tumors than sclerosing stromal tumor. So as I've already said, this is not a sclerosing stromal tumor, although the description of this tumor, the way I'm going to describe it is going to sound very familiar with the last case. So what we see as scanning magnification is an alternation of, it's a nodular, a lobular growth pattern. In this sense, a bit more well-formed, not that pseudo-lobular appearance, but a true nodular or lobular growth pattern in the sense that we, at least focally, do seem to have well-formed cellular nodule or lobules or islets. Another thing that we notice is that these cellular nodules tend to show prominent hyalinization, especially centrally. And there is an interlobular edematous to loose collagenous stroma that shows, at least focally, prominent dilated blood vessels. Going a bit to higher power, we see that the cellular nodules have preserved hypercellular areas at their periphery in sort of a rim at the periphery of the nodules, and they get increasingly less cellular and more hyalinized toward the center. The interlobular stroma, again, collagenous, sclerotic, with these thin-walled, dilated, and sometimes branching blood vessels, staghorn vessels, in essence. Another area showing the same thing, the staghorn-like vessels and that loose collagenous interlobular stroma, the cellular lobules with central hyalinization and a rim of hypercellularity at the periphery. In those hypercellular, in the cellular nodules at the periphery, the cellular component seems to be growing in branching, anastomosing, compressed tubular structures, while towards the center of the nodules, we see how this extensive hyalinization is compressing the tubular structure in what seem to be sort of slender cords and compressed trabeculae. These are two higher power images of that central area of the nodules where we see prominent hyalinization, and the cells, the tumor cells, are being compressed into these slender branching cords and scattered in a paucicellular manner. But actually, what is diagnostic in this tumor is not that central. It's not those central hyalinized areas of the lobules, but the periphery of them, where we have more cellularity. So examining the cellular areas at the periphery of the nodules is what's going to give us the diagnosis. And what we see here are these solid and sometimes hollow, tightly packed, branching, fusing tubules, that are lined by cuboidal to columnar cells with bland ovoid nuclei, some pinpoint nucleoli here and there. And the cytoplasm is pale, eosinophilic, nondescript, right? And again, notice the tubules, compressed tubules that are sometimes merging in these more complex aggregates on the right-hand side picture. Other areas show hollow tubules, tightly packed, lined by the same cell type, as well as other areas where there's a more diffuse growth pattern where these cells tend to fuse, they merge, and they form sheet-like patterns, whereby the tubular pattern on the left is the one that's gonna or should give you the diagnosis in this case. Regarding its staining profile, as you might have noticed with these last two cases, immunohistochemistry is not necessarily that useful and morphology trumps it. But this tumor is positive for sex cord markers of sex cord differentiation, would be positive for calretinin, inhibin, SF1, W21, and CD99. It is positive for high molecular weight cytokeratins, negative for CK7 and EMA, and it is PAX8 negative. So as I already said, I see it's not the thing that you have to cling on in this for the diagnosis, but morphology. So summarizing, looking at the cellular and the less sclerotic areas, we see hollow and solid tubules and anastomosing trabeculae. So any ideas what this could represent? That's a good differential. Skedat is a good differential. The sclerosis so skedat usually a typical skedat will have these hollow tubules, right? Cribriform structures, almost that have this basement membrane like hyaline material in the lumen, and the cells that and the cells that are arranged in a they're polarized, right, around the hyaline membrane, basement membrane like material, and at the periphery. But sometimes you can see fibrosis in skedat. Fibrosis in the sense that you can see bands of fibrosis between the cellular areas that kind of merge with that basement membrane like hyaline material inside the lobules. In this case, the fibrosis is mostly, let me show you, is mostly outside of these cellular structures. Like even when they fuse and they form sort of kind of cribriform structures, you don't see that hyaline material in the lumen of that cribriforming. You mostly see the sclerosis on the outside compressing the structures. So skedat is a good differential, but it's not that in this sense. And you also don't see that polarization of the nuclei. Another differential. Any other ideas? Does this image remind you of something? The one on the left-hand side of the screen? Something that you may see in a, yes, Sertoli cell tumor. Sorry. It's a Sertoli cell tumor. Reminds of what I wanted to say, that it reminds of immature seminiferous tubules in the testis. Yes, this is a Sertoli cell tumor. It's actually a Sertoli cell tumor with prominent sclerosis. And that's what I wanted to show here. This is another beautiful article that I highly recommend you read. It's about exactly this phenomenon that before this article was published was only alluded to in the literature. It's related to sclerosis occurring in sex cord-stromal tumors other than sclerosing stromal tumor, because when we see sclerosis, when we hear about sclerosis, we tend to think about sclerosing stromal tumor just because sclerosing, it's in its name. So, but sclerosis is not something that is limited to SSTs in the realm of sex cord-stromal tumors. And the authors identified two major morphological patterns of sclerosis in ovarian sex cord-stromal tumors that were irrespective of tumor type. And those two patterns were the sclerotic pseudolobular pattern, where they saw sclerosis in between cellular nodules, which led to a sort of pseudolobular appearance that mimicked SST. And this is something that they mostly saw in thecomas, in microcystic stromal tumors, and in both juvenile and adult granulosa cell tumors. And then the other pattern was the compressed chordoid or tubular pattern. It's exactly what we saw here, right? Let me show you, because it's better when you see it. It's exactly what we saw here. Like the central areas of those nodules had prominent hyalinization, which compress the typical Sertoli cell tumor tubules. Yeah, so in typical Sertoli cell tumors, we have hollow or solid tubules, right? But in those that show sclerosis, we have compression by the sclerotic stroma of these tubules in sort of slender cords that branch and are very paucicellular. They're very scant admixed with this sclerosing stroma. So this is what they describe in Sertoli cell tumors, but also in Sertoli lytic cell tumors, in adult granulosa cell tumors, and in scatat. The key to the diagnosis here is to be aware of this phenomenon, to do rigorous sampling, because in most of these tumors, you're gonna see areas that are typical for that respective tumor type. So although sclerosis, when it is present, usually leads to one of these two morphological patterns, irrespective of the tumor type, if you sample good enough, you're going to see areas that are typical of the morphology of these tumors. So you're going to be able to make the diagnosis. And of course, examination of the cellular areas and not of the sclerotic areas is going to help you in making the diagnosis. Ancillary testing, IHC, molecular analysis may play a role, as for example, you will see FOXL2 mutations in a granulosa cell tumors, and you won't see it in a Sertoli cell tumor. Can help, but immunohistochemistry, not necessarily that much. Most of them are positive for markers of sex score differentiation. So you really do have to rely on good grossing, good sampling, and examination of the cellular areas that you have in the tumor. Okay, very brief on Sertoli cell tumors. Rare, less than 5% of all sex cord-stromal tumors tend to occur in young patients with a mean age of 30 years. Clinical presentations is nondescript abdominal pain related to pelvic mass. Occasional cases are associated with Poitz-Jeghers syndrome, and this may be important to know, to remember. Hormonal manifestations may be seen. They're usually estrogenic. Like we talked about, precocious puberty in girls, or the whole spectrum of abnormal uterine bleeding with disorder proliferative, hyperplasia with or without atypia, and endometrioid carcinoma. And the prognosis is mostly good, excellent. Most cases present at stage 1, but they can also show malignant behavior, these tumors. Grossly, they're usually unilateral. They are mostly solid, but they can be cystic. And they have a tan yellow cut surface. Histologically, the most characteristic growth pattern is this admixture of hollow or solid tubules. They can grow in a diffuse fashion, or they can show these lobules as we've seen in our case. Other patterns that are usually admixed with the tubules are trabecular, corded, retiform, spindle, whatnot. They can even have a pseudo-endometrioid growth pattern. That's why endometrioid carcinoma is one of the main differential diagnoses here, because endometrioid carcinomas are carcinomas and Sertoli cell tumors are usually benign. So that's an important distinction to make. And this is one distinction where immunos will help. The Sertoli cells, they're cuboidal or columnar. They have oval nuclei, pinpoint nucleoli. Sometimes they can have clear cytoplasm, lipid-rich, or they can have prominently eosinophilic cytoplasm, the so-called oxyphilic variant. And these two variants, the lipid-rich and the oxyphilic, are more commonly associated with Poitz-Jeghers syndrome. So if there's no known history of Poitz-Jeghers, you might want to check the chart, check the history, see if there's any association. You can see occasional lytic cells in a predominantly tubular tumor. This does not preclude the diagnosis of a Sertoli cell tumor. You do not diagnose it as a Sertoli lytic cell tumor if you only have just a minor scattered component of lytic cells. And the stroma, as we said, it may be nondescript, they may be scant, or may be very prominent, abundant, and hyalinized, which usually results in this compressed cords and tubules pattern. Chemically, the sex cord markers are positive. And maybe most important to notice here is that they're negative for PAX8 in regards to the differential diagnosis with endometrioid carcinoma. Molecularly, they have DICER1 or STK11 mutations, and they don't have the FOXL2 mutations that you usually see in granulosal cell tumor. There are some histologic features that can be used, sorry, to predict aggressive behavior, which are the size of the tumor. So grossing is important, again. Cytological atypia, mitoses, with the threshold being set at more than 2 mitoses per 10 high power fields, and necrosis. So it's good that we can look histologically and look for certain parameters to predict the prognosis of an outcome of these tumors. And here I've listed for you some images. This slide is very busy. It's intended to be like a wall hanger on Sertoli cell tumors. I can share it with you if you're interested, as it has like all of the characteristic features. So that's why it's so busy and packed. Okay, last case, very quick. We have an ovarian tumor. There is a history with this case, but I'm not going to disclose it because otherwise I would spoil the diagnosis. But keep that in mind. We have a growth pattern that is mixed between nodular and diffuse. We see some nodules and we see some diffuse growth of the tumor. We also see that we have a collagenous stroma. We do have some thin-walled, dilated and branching staph-formed blood vessels, not that prominent in this field at least, but we do have them. And the tumor cells grow in kind of trabecular, anastomosing trabeculae mostly. Again, another area that shows the vascular pattern, the collagenous stroma, and that sertoliform growth or sex cord-like growth, right? Because when we see a tumor like this, we instantly think that this could be in that spectrum of sex cord-like tumors, right? Another area where there's more of this diffuse growth, not that well formed trabeculae or tubules we haven't seen until now in the tumor. And again, areas where we have like pockets, nodules of hypercellularity with mostly anastomosing trabeculae of these very small cells, high NC ratio, right? There are other areas that kind of resemble in a sense a Sertoli cell tumor, in the sense that you have trabeculae, you have that are anastomosing, maybe some compressed tubules, why not? Right, and the staining profile kind of fits. You do have positivity for sex cord markers, carrageenan, inhibin. Inhibin was negative in this case, as it may be in this tumor, but sometimes it's positive, so it's variable. WT1, CD99, CD10 was positive. But we do notice from the staining profile that this is a very polyphenotypic staining profile with the sex cord markers on one hand, the epithelial markers, the broad spectrum cytokeratins being positive, the smooth muscle markers, SMA and Desmin, and also positivity for ER and PR. So this is a tumor that kind of stains in a very peculiar fashion, has all of these markers of different lineages, so to say. So any idea what this could be? Any last ideas for this last case of what this could represent? A good differential, granulosa cell tumor. Let's jump right to molecular and say that this doesn't have a FOXL2 mutation. To help you, there is a known history of a uterine tumor. So this is a metastasis or a recurrence, extrauterine recurrence. after an original diagnosis of on a hysterectomy. Very good. D. diff, undiff. Those are mostly ER/PR negative. And they tend to kind of lose thyroid expression. It's mostly focal. This one was pretty positive. Endometrioid. Good. That would be Paxate positive. And this is not. And well, endometrioid carcinomas can have sex cord-like differentiation. So that is a very good differential. And this is not it. And also, endometrioid carcinoma doesn't have this polyphenotypic immunoprofile with SMA and desmin in the same tumor cells. So it's not that. What could it be? P53. Not aware. Wild type. I think it's wild type. It's not a serous carcinoma if you're thinking about that. No, because not an MMT. Because that would be a carcinosarcoma with a new terminology. It's not, because we don't have the two components. We don't have a carcinomatous, malignant epithelial, and a malignant mesenchymal component. It's not biphasic neoplasm in that sense. This tumor has recurrent NCOA 1, 2, or 3 fusions, if it helps. It's mostly benign. It's mostly benign. Very rare cases reported to show recurrences and metastasis. It's considered a low malignant potential tumor. It usually has a combination of spindle and epithelioid cells with prominent sex cord-like differentiation. Yes, uterus, uterine tumor. This is the name of the tumor. Literally, this is the name of the tumor. Uterine tumor resembling ovarian sex cord tumor. Uterus. And in this case, this was an easy case in the sense that there was a known history of uterus on a previous hysterectomy. One of the, I'm not going to keep you any longer, but just one thing to remember about uterus is that you have a tumor which has prominent sex cord differentiation. The one thing, when you're in the uterus at least, the one thing that you want to exclude is an endometrial stromal sarcoma, and that's what most people didn't mention. Endometrial stromal sarcomas, especially low-grade endometrial stromal sarcomas, can show sex cord-like differentiation. And while some authors say that sex cord-like elements in low-grade ESS are usually less positive for sex cord markers, or can be negative for sex cord markers, that's not always true. They can also be positive. So that's the main differential. And actually, historically speaking, originally these tumors were described together with endometrial stromal tumors. Actually, the first description was of a tumor, a uterine tumor resembling a granulosa cell tumor. And then there were the group by Scully described these tumors as part of the endometrial stromal neoplasia group in two groups, the low-grade endometrial or the endometrial stromal neoplasms with sex cord-like differentiation, focal sex cord-like differentiation, and then the tumors that show predominantly sex cord-like differentiation, which subsequently emerged as a separate entity, which is uterus. And why it was separated from endometrial stromal tumors, it's because they do not show the typical JASF1 sus12 or PHF1 rearrangements that endometrial stromal tumors show. They show recurrent NCOA 1, 2, or 3 rearrangements, and the usual fusion partners are either estrogen receptor 1, ESR1, or REB1. REB1 stands for growth. How is this? Growth regulated by estrogen in breast cancer, something of the sorts. And these are the main two fusion partners. There are some reports with CTN and B1 alterations, rearrangements, but so they emerge as a separately morphologically and molecularly. And the essential thing to remember is if you see something like this in the uterus, you have to sample accordingly and be sure that you do not see a component of typical endometrial stromal neoplasm, because if you see that, it kind of excludes the diagnosis. And I think I'm pretty much done because it's late for me, and for some of you guys it's early and you want to enjoy the rest of your weekend. So I hope you enjoyed. I haven't been as coherent as I usually am. I'm very tired. I'm sorry for that, but I hope you've enjoyed the cases at least. And the recording is going to be available on YouTube for you to look at again. Hope you enjoyed.